So we're just going to go through the placement of a standard spinal cord stim lead.
Great, thank you very
That's the
much.
plan. And our leads are here. Lead or anything? Water. So as we were talking about earlier, you're not always faced with the simplest of spines. And here we see a variety of things going on with this patient with looks like plastic. In addition, nice to get some perspective on what's going on with the spine and get some the distance to the epidural space. Taking the liberty of placing a small 22 gauge needle and advancing that to an area that we'll try to get into. It looks like there's a fair amount of osteophyte there, so it may be a little bit of trouble getting in that spot. We'll see once we get closer. Let's go ahead and take this to a contralateral view. And with the view, we can see the angle of the needle. You can see the lamina there where the needle is placed, and the same angle as the needle, and that would be a great trajectory for entering the epidural space. There is some osteophytes there, so we'll see if there's any real openings. Rotate degrees towards me. There you go. So if this were a patient you're trying to keep alert and responsive, you can use that spinal needle to anesthetize the tissue really well. Down to the lamina. Using that trajectory, replace the spinal needle with your introducer needle. Not quite two vertebral bodies down, just sort of to the medial aspect of that pedicle. I like to use the angle of the spinous process there. Looks like a triangle. So if I can get parallel to that as it's coming out there. Once again, let's check our contralateral oblique. Make sure we have the same view that we had earlier. You can see that's coming right over that lamina. Yeah. No plastic ones, huh? Yeah, plastic. I prefer plastic. Yeah. And we'll use the loss resistance technique to... We do have a plastic... no, I'm sorry. That's not a loss resistance syringe. Identifying where your bevel is. We're tilt a little bit to the right there to...
Tyler?
There's a loss resistance syringe. Good. Thank you. All right. And we can check again. And as we can see, it's sort of sliding right past that lamina there. Should be in the epidural space now. Keeping the bevel at about the 1 o'clock position. I'll sort of see how it comes in, trying to maintain the curvature more dorsal.
And Dr. Poree, what would you say for our audience the angle at which you're entering with the needle to the skin?
Less than 30 degrees at this point.
Excellent.
And I'm going to sort of position this more to a 12 o'clock position as we come out. And then try to stay along midline using and you can see there a little bit of blockade there, maybe an osteophyte on the surface, but stay along midline and then make your decision about what your target is. So here we are, 12, 11, 10. So if I just want to be paramedian, let's say at the 8, 9 level, this would be about the spot that I would sort of start to go a little bit lateral and straighten up. And sort of have a lead in that position, then test it from here. I actually like some of the simple plastic anchors for my trials even. I anchor them to the skin so that people can do more activities without a lot of migration. But that's pretty much the placement. And are there any particular questions at this point?
Questions from the audience at all, right at this point? The question was from the audience if you're not checking very many laterals if you're midline.
So if I haven't switched at all, I try to get into position, but then I'll, at this point, would check a lateral. Unlike a DRG where I wouldn't know the final position until I check the lateral view. If I'm doing standard spinal cord stim, I would check my contralateral as I'm positioning initially, and then advance up to my target level, and then check my lateral view. Making sure that the lead is sort of on the dorsal aspect of the spinal canal there.
And just to confirm, you're using that contralateral oblique view to help confirm how close you are to the lamina?
I like the contralateral view primarily to look at the angle of entry into the epidural space. Once again, we can see that needle right here. And just come in just a little bit. No, just come in. There. And the lamina really line up well here. And you can see how I'm at the same angle as the lamina and entering the epidural space lower in the intervertebral space. So it gives me a little bit more working room for when the needle comes out and then makes the cephalad turn.
Excellent. Further questions from the audience? Is there a possible time to get a DRG stim trial done right now?
If I have one.
Yeah, can we get that underway for the audience? You worked through that so quickly that we have some extra time. I think it would be beneficial to our audience to see one done here.
So we certainly have some challenges here with spacing, but let's come further south. Lots going on with this spine, of course.
Yeah, we used these spines yesterday's cadaver day for the vertebral augmentation.
Great.
So there's a few areas of contrast cement there.
So since where's one of your needles? Oh, here. Okay. So our first plan is to get our lead and sheath in position. I've never quite done it this way, but I'm going to give it a try today to see if it works, just so people get some perspective. Because I think this is a key opportunity to look at the difference. So this needle entry for the spinal cord stim lead. And for the DRG placement, I'm going to try to get into the same space, and I'm not really sure it's going to fit both needles, but we'll start anyway. But I'll go with the same entry level and just come a little bit more lateral to that. And then sort of a view here. What we're going to do is try to aim for the DRG right underneath that pedicle. And then angle it down toward the level. So with a straight line from the contralateral pedicle at the level we want to enter, come down to approximately 2 vertebral bodies, and then enter the skin at that level. So we're starting far lateral to that. The same angulation. All right, let's take that contralateral oblique view again. So you can see it just a tad bit steeper than the other, but close. And let's go back to AP. So ideally, maybe a little bit less of an angle, but I'm still less than 30 degrees on this one as well. So the needle here not really getting the greatest of losses, but let's go ahead and go to contralateral oblique again. All these approaches, I'm not getting the best of loss with this, but let's go back. Felt like a decent loss there. Can you pull back a half inch? That's good. So reposition the bevel. Actually go north 2 inches there. There you go. And you can see there's something obstructing our path that we want to use. Yeah, maybe this level is with this prior procedure, it may not be the best. Because that's too low and it doesn't want to go to where, yeah. Let's come down south and see if we can find anything. So each one, I can see now why you're doing vertebroplasty here. It's a lot of cement in the way here. Let's go on the other side, actually. So starting down again about 2 levels below, aiming for the contralateral side now. Open up the C-arm a little bit. C. There we go. Let's go ahead and do the contralateral oblique, but this time on my side, not the other way. There you go. Pull back. Right there. Okay, so we're coming right across that lamina, sort of lined up nicely with that. Back to AP. Come on in. And open up the C again. Open. Great. Lock. 2 inches north, please. 2 inches north, please. Right there. There we go. That's no obstructions there as much. So we're aiming for the, let's say, the 5 o'clock position of the pedicle. You can see the little line in the front. That's the end of the sheath, and then the 4 contacts that are within the sheath. Once we hit the bottom of the pedicle there, approximately 5 to 6 o'clock, then using the curvature of the sheath here, we sort of continue to advance. North another ½ inch. There you go. Good. Can you columnate for me from the sides? More. Okay. And now, there you go. Straighten up. Good. That's good. All right. And then we'll try to get past that ligament. It comes up to there we go. Just past another one of those ligaments there. And so we're between the 2nd and 3rd contact there. Now is the time to loosen the sort of the connection between the sheath and the lead. And you can see that line being pulled back. That's the sheath being pulled back. I'm going to pull it back to approximately there. I'm going to now pull the stylet back between 5 and 10 centimeters. Change the angle of the sheath and now push up. Can't really see it that well behind all that cement, but it's looping up some. And I'll pull back some more on. And I can't see behind the cement there either. So I'm going to reposition the sheath again, pull back a little more stylet, turn the curvature again. Pull out more stylet off of the lead, feed in more, creating some loops there, turn again. Let's take a lateral view now and see what the alignment is of the leads inside of the foramen. Looking to make sure that they are posterior to the vertebral body and that they're aiming more out at us. You can see how, can we mag that, mag 2? Mag again, great, thank you. Come south, please. Tad bit more. Right, there you go. So you can see how the leads are posterior to the vertebral body, and that the two circles you see mean that the leads are actually facing straight lateral in that view. So this is a good position to be right over the DRG. Go back to AP view. It's a lot easier to see it this way without the cement in the way. Let's see here. No, that's fine. And I'm going to position this a bit. And I'm going to turn this way, advance the lead a little bit more. There we go, giving us some of that curvature there. Pull back that a bit, turn the lead in the other direction now. There we go. So getting an S curve there. And for a trial, I would solidify that in place. That contact, third contact is a little further out than I like it, but that's in essence. Let's go back to the lateral. Still over the DRG there. More of a challenge to see everything with the contrast. But yeah, you can still in decent position. So I would certainly trial that and see how it goes. And if I get good simulation, this would be a great position. For the permanent, I might like to have that last third contact out a little bit further. Any questions?
Questions from the audience? Question is that in comparison to standard configuration trials, with the DRG trial, do I get less migration or more
Migration?
migration than the leads? Yeah.
I'm sorry to make sure I heard that.
Like-
More or less migration, you say?
Correct. Yeah.
Yeah, it's a migration issue. With good amount of slack there, I haven't seen any migration. I think it's depending on the anchors you're using. Like I say, the anchors. If you compare it to the old spinal cord stim anchors, I would say it's certainly less.
Okay.
With the new spinal cord stem anchors, they're all pretty decent. And so I'm seeing very little migration with those as well. They might migrate, a contact or two here or there. And so certainly with the dorsal root ganglion stimulation, the loops that you see here might migrate, so half of that loop might come pull back, but that's why we put the loops in to allow for that flexibility, but the leads themselves usually stay in place. Very little. So in both cases, I'd say about the same amount of migration rate with the current non-sutured in DRG leads as well as the anchored in spinal cord stim leads. Both have similar sort of migration rates.
Okay. Well, great. Well, thank you very much. That was great.
Sure.